Good afternoon. Can you see? Okay, fine. So last time we started with that. That is, there was a study, and that study has found what kind of drugs are there to, on the basis of their various effects. We have seen how we call them as a evidence-based study, and on that basis, how we can have categorization as a first line treatment, second line treatment, third line treatment, like that. And we have put certain drugs or certain treatment options into various uh, places. So which should be first line, which should be second line. Then there was a big study which was there was a big study which was conducted, and this study actually led to uh, many impacts, because this was one of the very big study. And that these were the drugs which we have put as a first line treatment, second line treatment, third line treatment. And there were certain drugs which we have put like unranked, example like anti-epileptic drugs, or pindolol, which is a beta blocker, and many people believed that it will be useful. So there was a study that was known as a STARDY, and that STARDY has tried to collect various evidences that what will be or what are the situation, and they rather started with working with the studies of various drugs augmenting to the antidepressant agents. Now, whenever you go for any kind of, may it be NICE guideline or may it be any other guideline, you will find that these all are various drugs which are mentioned in the guidelines, that this can be put or this can be added as a in addition to the normal antidepressant agent. These are also been there. So we shall see this is a lithium. It is actually used in bipolar disease. At many times depression is not alone, and it is along with that bipolar it is there. Now what do you mean by bipolar? That is, we have seen depression is a one pole, where the person is depressed, is away from, and it is its mood is very down. Okay. While mania is totally different, totally opposite to that of depression. We call it as a aggression. So depression and aggression, these both phases are existing a person, in that it is called as a bipolar disease. So this bipolar disease, the person can have very violent behavior at some time, to what we call as a maniac behavior, and at certain time it will be so depressed that can commit suicide, or feel that he is not of use to any society or himself. So these are totally two different poles of thinking are there, two different poles of mood are there. And in the various bipolar diseases, lithium has found to be very good agent. So there was around 10 studies were conducted, and total 269 patients were there, on which these various studies were conducted. And when the data was compiled, it was found that it is superior, this lithium is superior to placebo in augmentation of antidepressant effects. So in SSRIs, people can add lithium. In TCS, they can add that is tricyclic antidepressant, we can add lithium. And particularly it shows that 41% response rate, which is much more than placebo. That is, placebo shows 14%. I am sure you know about placebo. You know placebos?
Yes, sir.
Very good. So when it was compared with placebo, it was found to be more effective, it was found to be better. Then next is that is was STARDY, as I was telling. That is, STARDY was a clinical trial, and that clinical trial, that is augmentation. STAR means various treatment augmentation in depression. So STAR plus D. So they are abbreviations are given, but basic name is actually relevant for that particular studies. So lithium shows that it shows when it was added up to 900 mg per day for around 69 patients, it shows that good remission, and there was a 16% decrease in at Hamilton D scale. We have seen Hamilton D scale is one of the important scale. It is there. It can be added into citalopram or it can be added with bupropion or buspirone or any other such agents that which are antidepressants. Then next are atypical antipsychotics. Now antipsychotics are agents, they are preferred in schizophrenia like disease. Okay, these are working, and they can also be used in maniac phases because they are working there. But some of these, particularly this newer one, they are, we call them as atypical. We'll discuss about typical and atypical when we'll have antipsychotics. So in these antipsychotics, newer one, these are atypical one like risperidone, olanzapine, aripiprazole, and quetiapine. These four are found to be very effective and found to be very good. And out of that, these three, particularly risperidone, olanzapine, and aripiprazole, are the first line treatment. People believe, as per this network, as per this Canadian network, which is for clinical psychologists and which have given this. It ranks quetiapine as a second line, and there are many analysis has been done, and they are found to be equally effective in, and they are well tolerated. Now, what this atypical, AAP means not AAP party here, which is ruling Delhi. This is meta-analysis of AAP augmentation, means atypical antipsychotic agents. So these antipsychotic agents, it was found in various one. There are various studies where there, here n is equal to means you must be knowing about it. It means number of subjects which are participating, or number of observation actually in statistical terms. So olanzapine 1000, risperidone 386, quetiapine 1000, aripiprazole 1000. So almost except risperidone, they were similar, and various trials were conducted on that. And there were not found very big differences between various and these atypical antipsychotics. So there are various studies were conducted. So total 16 if you combine this together. So total 16 studies were done, and around 3000 patients were studied on that. And it was found again very good, superior in augmentation of antidepressant effects along with SNRIs and SSRIs. SNRIs means the selective noradrenergic reuptake inhibitors, and SSRIs, you know, that is selective serotonin reuptake inhibitors. So these are found to be very good because these are the first line treatments, SSRI and SNRIs. So what it was, odds ratio is, I must say that you must be studying in biostatistics. So what it is, the odds ratio is the ratio of the odds of the event occurring in one group to the odds of the occurring in another group. Means how much chances it is having, it is occurring in one group. Suppose there are 100 patients in one group, there are 100 patients in another group. So what are the chances of occurring in group A, and what are the chances in that, and the ratio is taken that is occurring group A and group B. So this is what we call as a odds ratio. And in other cases, that is NNT is the number of patients who need to be treated in, that is treatment is needed to prevent additional bad outcomes, because if they are not treated, then it can go for some mortality or morbidity, and it can be making a big impact on the life of the patient. That means that is the patient which is must be treated. It is important for that. So this type of data was collected simultaneously, and it shows that this was good one with various drugs, that is risperidone, aripiprazole, quetiapine, and olanzapine. So these all drugs are there. They have increased the remission rates. Here you will find that the remission rate was around 30.7%. Already we have seen that lithium was a good one, that is it has made around 41%. But problem with the lithium is very toxic, and you need in 5th year there is one topic you have got, we call it as a therapeutic drug monitoring. Then the drugs which are having very narrow index, therapeutic index, or they can become toxic in even the routine dose. In that, lithium is one of the drug. That means if anything goes wrong, if the patient does not pay good attention, then it can be toxic, and it can be severe toxic. So very good attention has to be paid on lithium. But lithium has been found to be very good in these patients. So various trials they have shown that how it was effective at these antipsychotics, that is atypical antipsychotics. They were quite effective. They were good one. Then risk benefit. Normally, this is what our science is. When we study pharmacotherapeutics, our basic role is to study risk benefit ratios, or rather benefit to risk ratio. We should have more benefits comparative to less risk. So what is the situation? The benefit with the atypical antipsychotic agent added as a augment. I hope you remembering the term augmentation. We have started with augmentation. We have seen earlier, we have seen the list of various drugs which are used in that. Initially we have seen that we are going for a single treatment. Anyone, you know it very good. So we are going for augmentation. So here, what's your drug we are considering? These all are for augmentation. So benefit are large, good one, but the risk of serious adverse effects is also large. It may lead to metabolic syndrome. It can cause extrapyramidal syndromes. It can cause the tardive dyskinias or neuroleptic malignant syndromes. And if you will go for, then you will realize that all these are the side effects which are there with the atypical antipsychotic, or other typical, they are having more. And as a consequence, the risk benefit ratio may be different than that of several alternatives. So we have to see other alternatives also. This is what triiodothyronine, that is we call it as a thyroid hormone. So T3 is a levothyronine. It is benefit in the open trial, and some of the randomized clinical trials it has been shown. The meta-analysis of various studies had shown that this drug has weakly supported the efficacy of T3 augmentation if they are added with the tricyclic antidepressants. Odd ratio is around 1.53. It is not significant, and in all trial it becomes 2, which can be acceptable, because it means that 2 persons are having benefit comparative to 1. Then how it is given? It is given 20 microgram per day for 1 month, followed by 50 microgram per day for 1 month. Then long-term safety is not known what will be happening if it is given. There is a big question on the risk for permanent suppression of thyroid function. If you know it, if you remember your physiology well, then you will realize that if T3 is there, T3 is very, very important in the regulation of thyroid gland function in body. That on the basis of T3 level, the TRH and TSH are released, that is thyrotropin releasing hormone and thyroxine releasing or releasing hormone. These two are there from hypothalamus to pituitary, and pituitary to this thyroid gland. So this whole feedback mechanism is there, that is using triiodothyronine concentration as a base value, and on that basis the negative feedback mechanism is working. So there is a risk of permanent suppression of thyroid function, because it may cause too much decrease of TRH. Because of that, the pituitary portion of that particularly thyroid secretion or TSH secretion will be having less activities, and it can go down. The long-term efficacy, the data is not sufficient, and because of that nobody can tell how much beneficial it can be. Therefore more research is needed to be conducted, and then it will able to, people will able to again, every time we need risk and benefit. So until and unless we know what are the benefits, that is not big one. Then apart augmentation is what the first antidepressant was being treated, and we found that our goals are not achieved. What's your score reduction in the maybe Hamilton or DS5 or any other called PHQ? These are various scales which we have seen. If we are not able to reduce it, then we added another drug and we call it as a augmentation. Now what if we combine it from the beginning? So we call it as a combination. This is what difference between augmentation and combination. Combination means from the beginning we are adding 2 drugs. It can be same pill combination, or we call it as FDCs, that is fixed dose combination, or it can be taking 2 tablets, 1 tablet of drug A and 1 tablet of drug B, then still we will call it as a combination, because they are concomitantly administered, they are simultaneously administered to the person. So what drugs we can consider? Example of these are metrazapine, bupropion, tricyclic antidepressant buspirone, which is an anxiolytic, having more like anxiolytic activity. What can be there? So some studies were conducted, and it shows that response rate is around 64% with metrazapine, and this 20% with the other one, and when we are giving it with this bupropion, SSRIs and venlafaxine, these are various studies which were conducted, and this found, these are the only one study is there, 26 adults. So this is not very good study, because very few patients are there, only 26 patients are there, and hence we don't have much information about that. The STAR-D was another study that shows venlafaxine plus metazapine. There was no placebo was added. It was a single blind. You must be knowing single blind, but anyway you will get it in clinical research when you will go for. So single blind means doctor is knowing about treatment, about it. Physician is knowing that which drug is given to which patient. If it is double blind, then neither physician nor patient knows it. So we call it as a double blind. So it is a single blind randomized studies. Randomized means patients are randomly selected. Venlafaxine plus metazapine after 3 failed antidepressant trials, and venlafaxine was given in the dose of 210, mean dose was 210 milligram. Just a minute. Just a minute. Hello. हाँ बोला. हाँ बोला. बरं ठीक आहे. ठीक आहे ठीक आहे ठीक आहे. ओके सर. So it was found that when metrazapine plus venlafaxine was added, it was shown the remission of around 13.7% remission in that, and response was good. Around 23.5% people shown good response to this. Then buspirone is there up to 60 milligram, or bupropion up to 400 milligram. Again, it was not a placebo control, it was a failed placebo control trial for buspirone, and it was found that when it is added to citalopram, what was the remission rate? There were 2 scales were used, that is Hamilton D scale and QIDS SR scale, and it shows that it causes decrease in 29.7%, while buspirone causes 31.2%. The other scale is 39 and 32.9%. So it shows that around bupropion is having comparatively better one if you consider both simultaneously. The response rate were better again in bupropion than buspirone. Here SR means sustained release. So therefore bupropion was found to be slightly better tolerated, and it was better one if we are combining. These are the combination one. Then tricyclic antidepressants, there were various studies which were there, and this study shows that when tricyclic antidepressants are added to SSRIs like fluoxetine or sertraline, or they are added to TCS, there were various studies, and it was found that 13 studies have shown good response. The 4 of these responded to addition of decimipramine or imipramine to fluoxetine, and around this 4, that is 36% of the 11 patient they found in the another studies. So the problem are what has to be, when we combine them, then there are problem. We need to have extreme caution, or rather we should avoid as far as possible. Why? Because most SSRIs, they inhibit the metabolism TCA. So because of that, there will be marked relation of TCA blood level and TCA or SSRI combined. And this tricyclic antidepressant, they have narrow window of safety, or we call it as a less therapeutic index, and therefore it can result into arrhythmias, and which can be very dangerous. So whenever these agents are given, I repeat, you will have to, when you will study this, we call it as a therapeutic drug monitoring. So we are particularly monitoring such kind of agents where the fluctuation in the blood plasma concentration can result into big toxicities. So we have to continuously monitor their plasma concentration, and this monitoring of plasma concentration we study under head that we call as a therapeutic drug monitoring. So here this is the class, or this is the drug where you need you have to monitor the therapeutic concentration. So these are another study, that is high dose fluoxetine with lithium, only fluoxetine alone and lithium or decimapramine augmentation of fluoxetine in partial responders and non-responders. So in that it was found that see how this study was there, either high dose of fluoxetine alone or combination of lithium plus fluoxetine or combination of decimapramine with fluoxetine, and what it shows is there was no significant difference in the response rate. Fluoxetine alone caused 42.4 response, while fluoxetine plus decimapramine causes 29.4, fluoxetine plus lithium causes 23.5. But the problem is too much fluoxetine can have toxicity. So that is another case, and therefore again it has to be seen that what it can be done or what has to be selected. Patient wise it has to be there. So since we have found that there are many such difficulties are there, whenever antidepressants are combined, more research has to be conducted, so that and more research means more number of patients and more robust, what we can say robust means where we have seen that in some of the cases there were no placebo are added, or some of these studies were not randomized, or number of patients were hardly 10, 15 like that. So if these less patients are there, you may not able to gather sufficient and good amount of data which you can rely upon. So the robust data is there, it should be there, and it should be checked whether it will be useful or not. Buspirone, bupropion and metrazapine are relatively safe, and they deserve early consideration in the treatment algorithm. See, this is a very important thing which is there. Whenever we are going for algorithm, when we are planning about it, we have seen algorithm earlier and we started with one drug. So which should be one drug? Normally we call it SSRIs, that is fluoxetine or fluoxamine or paroxetine, like this drug. But as far as possible, even these drugs are very good, metrazapine, bupropion, buspirone, this can also be added into it. Then there are various randomized controlled trials are there, and these are short-term trials of methylphenidate are there, then modafinil is there, then there were other trials are there, and they were not sufficient enough. That these are psychostimulants, and actually most of these are used or abused, like if you have studied amphetamine somewhere earlier. So these are agents which are causing maniac type of effect or psychiatric effect. So these are the agents. So these are psychostimulants, and they are not much useful. It has been found that they are not of big use. So again here also big research is needed, because earlier theoretically some of the people have, if you refer the previous one, we have found it in level 4 type of for evidences. Level 4 means here on the basis of their impact or pharmacology effect, the clinicians believe that they can be useful, and when more than one or more than few group they believe that yes it can be happening, then it is a level 4. Level 4, why it is level 4? Because it is just belief of the people and it has not studied, and this study, if it studied, then it will cross the levels, or it will come up, because level 1 is the very clearly randomized clinical trial, more than one clinical trial, which is very clearly, which is at and this all these different trials are conducted at different places, and their outcomes they are having almost similarity. Then we call it as a level 1, which is very very sure, which is very very confident one. So here we are going for these psychostimulants. More research is needed, because so far whatsoever trials are there, they are not sufficient enough. Then some anti-epileptic agents are added into that. Example of this: carbamazepine, lamotrigine, and phenytoin. So this, what are the effect of this? So it was with carbamazepine, it was found when augmented with SSRIs and TCS. So it was found that carbamazepine 20, this 57%, lithium 68%, and they are equally effective, while lamotrigine also having good effect, that is 66%. Phenytoin, see here the case to case or the studies are different. Here it was in 99, it was a different case. You may get confused that somewhere you find that 41% was lithium, now it is 68%. Why this? Because this is a different study. Then phenytoin was there, and it was comparatively less than the other one, like lamotrigine and carbamazepine. So these are what various drugs they can be added, and accordingly what kind of effect they are showing. But unfortunately, again here you will find that the number of patients are too less, and therefore we are not sure. And further there are difference also there. Example, lamotrigine was 63 days study, lithium was 28, this one was phenytoin was 28. But only thing is, yes, that has benefited, that is augmented, that causes 18% benefit. That was what the benefit is. So anti-epileptic medicine, it does not support the use of anti-epileptic as augmentation strategy for relief of unipolar major depression, because other are there. Although carbamazepine is effective, but we have found other drugs are more effective comparatively, and even we don't have sufficient data because number of patients they were less. So while augmenting anti-epileptic agent, at least for now, they are not preferred. Then pindolol was done. Pindolol is a beta blocker, and various studies were there, and it was again not that successful. Then some of the nutraceuticals were added. Example of S-adenosine methionine eicosapentaenoic acid, that is from fish oil, or to what we call it as omega-3 fatty acids. Then epiandrosterone, this is the hormone. Then tryptophan, which is converted into 5-hydroxytryptamine, and therefore it was believed to be one of the very good agents. And folic acids and inositol. So these are various nutraceuticals were tried, and again there is no evidence for its use as an augmenting agent, and its use should be only considered carefully given possibility of serotonin syndrome, because it can cause too much release of syndrome, and it can make problem in that, and therefore it is not that recommended. Then omega-3 fatty acids, we don't have big data, but only level 1 evidence from published studies for efficacy of omega-3 is augmentation in the mild to moderate major depressive disorders are there. Only they can be added. These are the polyunsaturated fatty acids, and they can be put into, they can add it. Then this we don't have sufficient data that it can be benefit as a augmentation agents. You can use it as a third line treatment only if the first line and second line is not useful, then it can be there, and we don't have sufficient data. So this is one more agent which can be added. Tryptophan, as I told you, it is a dietary amino acid which is converted into 5-hydroxytryptamine, and this that is serotonin, and it is centrally and peripherally very active neurotransmitter. Most of the trials show negative result with tryptophan augmentation of SSRIs or TCIs, and that means it is not useful, or it is rather making the condition not that rather worsen, maybe not worsening, very worsening, but it is bad than the previous one. And insufficient evidence to confirm benefits of tryptamine in the augmentation of antidepressants. Folate inositol, again there are no clear benefits of the inositol carbocyclic polyol as a monotherapy or even in augmentation. So again, although there were beliefs of the scientists, but some of these drugs are not useful. Then there are certain herbal treatment. If you go for, if you try to go for Google search and you put it depression herbal, you will find that so many advertisements like this will come up. So they are coming and they will put it in a depression when or they will make the advertisement available while you search for depression, but they will not directly claim it, and they will supply, or they will say that yes, it can benefit. These are available as nutraceuticals, but if you find the studies and their effects, it will show that there are little or no data regarding usage as an augmentation strategy. So these are not that much useful. Then nutraceuticals, which are there, only we have found that omega-3 fatty acids, they are somewhat useful, and it can be added as such, or it can be made as a dietary supplements. Other agents are no use. Then psychostimulation, there are done by various ways, phototherapy, then vagal nerve stimulation, then transcranial magnetic stimulation, and then electroconvulsive therapy. These are various therapies which are done. Example, so these are how the effects are. The dose is light is there, that is light is put, that is 100 lux, and lux is a measure of intensity of light. So standard daily dose is 10,000 lux for 30 minutes, which is given in the early morning. Response usually occurs within 1 to 3 weeks, and no study have examined the combination of light therapy and antidepressant in the treatment of seasonal depression. And there was evidence for efficacy of light therapy in seasonal depression. It is recommended as a first line treatment. So this is new finding, it has come out, that is phototherapy can be a first line treatment, it can be added. Then vagal nerve stimulation, that is implementation of a bipolar electrode around the left vagus nerve, which is accessed through an incision of the lower neck, and this wire is connected to the some electric supplier, and electric supplier are given in between. So there are no sufficient evidence, insufficient evidence to recommend and the combination of this vagal nervous stimulation and any antidepressant medication, because no big results have so far found. Then transcranial magnetic stimulation. So this is what magnetic stimulation is done across the cranium, okay, and combined use of this transcranial magnetic stimulation with antidepressant medication accelerate the response under sham control. Sham control means similar control or similar situation. It means if this magnetic stimulation is given, then other group is also given magnetic stimulation, okay, and everything is made almost similar. That is called as a sham control. So adding open label metrazapine increased the response to this monotherapy, and that evidence was called as a level 3 evidence. Not that good, but yes, it shows that beneficial. Response and remission was there, around 25% for active treatment and 9 to 6% for sham treatments. If 9% in sham treatment, that means these were the patients who were actually showing response. It was not actually impact of the drug. So this is how it has to be calculated. Then electroconvulsive therapy, the patient who have failed one or more adequate antidepressant medication trials, the ECT rates are around 50 to 60. Combination of ECT and antidepressant does not increase the therapeutic effect of ECT. Augmentation of nortriptyline with ECT increases the remission rate compared to ECT and discontinuation of nortriptyline. This is a level 2 suggestion. So only this nortriptyline is there, and it is comparatively better. When nortriptyline is added with the ECT, it shows better and augmenting effect. Now what is the summary of psychostimulation? Phototherapy, no evidences for augmentation. Vagal nerve stimulation, no evidence for augmentation. But transcranial magnetic stimulation show level 3 evidences which combining with the medication, and electroconvulsive therapy shows level 2 evidences which favor combination with the nortriptyline only, and therefore enhance remissions. So overall, then next is a psychotherapy, or we call it as a CBT, that is cognitive behavioral therapy. Most studies are combined therapy versus psychotherapy versus medications, and there are many studies are there. This shows the maintenance of antidepressant during the first year follow-up. It was found that there was a relapse rate and response. 47% relapse rate in the clinical management group and 27% with the CBT, that is cognitive behavioral therapy, was there. So that means that relapse is comparatively lesser in this CBT. Small statistically significant effect was found on the residual symptom levels, and after 6-year follow-up, effects of CBT in prevention of relapse and recurrent, they were persisted, and that means it is useful. So on all these studies, now what is our final opinion, what we understand from that, whether we have changed our mind? Because if we have seen earlier one, uh, earlier slide was there where we have made one this list, that is what are the first line, what are the second line, what are the third line, what are the unranked, and what are their impact, and then what actually all these studies lead to, what information it gives us. So first line are, out of that quetiapine is not that supporting, okay, and this is now, this rearrangement is there. What are the first line which are there for mood and anxiety treatments? So in that we can have aripiprazole, lithium, olanzapine, risperidone. They are comparatively better than quetiapine. So second line treatment, bupropion is showing level 2 evidences, mirtazapine showing level 2. This one, triiodothyroidazine, is not that good, shows level 2 and not beneficial rather. Other antidepressants, some of these are showing level 3. Fish oil was level 1, it was found that effective. And the third line like buspirone, modafinil stimulants are there. Ziprasidone was another antipsychotic agents. So these are what different one. Out of that, only TMS and ECT were found to be beneficial, only level 3 and level 2, and which are not proven effective are anti-epileptic treatment and pindolol. So these both are having no big effect, so they have not proven anything. They were earlier put as a fourth line. So this is how we are selecting the drug. This is how our strategies or algorithms and guidelines for our depression. So next we'll go for bipolar in next class. Please go through it. Most of the treatment will same. Some of the drug will just be modified. Then after bipolar we'll go for schizoaffective, where there is a combination of schizophrenia and this, we call this depression like or mood changes diseases, we call them as affective diseases. So the combination of this with affective and schizophrenia, we call them as a schizoaffective. So we shall go one by one, what are schizoaffective, what are these affective disorders. So we have seen first of from affective disorders, and slowly we'll go for others.